Good morning. I want to talk to you about IHME COVID-19 projections for the United States and strategies to reduce the spread. I'm deeply sorry that I cannot be with you in the meeting due to COVID-19, of course, but I will be happy to answer all the questions, and my email will be provided at the end of the presentation if you have any follow-up questions. This presentation is being recorded on Saturday, 28th of August, of course. The history of our model, it started by a request from UW Medicine here at the University of Washington, where they wanted us to provide them with projections of how many beds they need for COVID-19, how many ICUs and ventilators and oxygen, of course, because of the high burn rate of oxygen for COVID-19 patients. And we started doing this for our university and for our own catchment area here in Seattle, which is King County and Snohomish County. And we started doing this, of course, for every state. And now we do it on a regular basis, on a weekly basis for every country in the world. We utilize a lot of data from a lot of sources, including mobility data from Facebook and Google. We have questions in Facebook and Google that will tell us how many people are using masks when they are outside their homes. Of course, we have testing, we have vaccination, we have available vaccines, and we have, of course, waning immunity of the vaccine and cross-infection immunity from one to another variant. Before we use any of the data, of course, we have to fix the data. Data comes to us from different sources, but there is sometimes delay in reporting. This is an example from the UK, where you could see, for example, on weekends, there is no data available or not provided. So if you look at today, for example, when I'm taping this, yesterday, Johns Hopkins reported 3,156 deaths yesterday in the United States. So you see the numbers go up and go down, and we have, of course, to fix these issues with all the data sources that we get before we proceed and do any of our analysis. And we look at all the variants that are circulating using the GIS data. We know what variants, what percentage of them are circulating, and what variant is taking over in a location, for example. And we incorporate on our models the speed of invasion of each of the variants, the increase in attack rate, the increase in mortality rate, the decrease in vaccine efficacy, which is very important, and of course, it breaks through in immunity from previous infections. And we do all of this before we proceed in our models. This is, for an example, B117, how it spread in many countries, and you could see it spread so fast, it took over. This has happened here in Michigan in the past, and it took about 109 days from it to go from 1% to 80% in a location. And then when you look at B1617, or the Delta variant, that now is the more predominant variant circulating in the United States, again, it went much faster, and it took less time for it to basically compete with other variants and take over, and became the major one dominant in every place. And that's true in many countries we have seen. So you could see how it spread in Maharashtra, for example, in India, and it followed the same pattern when it came to the UK, and same in Gujarat in India. And again, when it came to the United States, it followed exactly the same patterns of taking over. And here is B1617 and how it spread so fast globally. If you look in May 1st, 2021, and in August 16, and in November 1st, 2021, that's what we are projecting ourselves. You could see that it will be the main dominant variant, with some exception in certain places where we believe they will put measures in place, such as in China, strict measures in place to prevent the spread of that variant in their own country, but it will spread eventually, but it will take a longer time to take over in a country. And we look at waning immunity from a lot of studies. So today, this slide is based on the data that was available. But yesterday, there was a study from Qatar, my colleague and my good friend, Lais Abu Raddada, that showed that even after 6 months, about 75% immunity against severe illnesses and mortality. But we need to look at it more carefully and put it in context with other studies. It showed 0% protection against infection after 6 months, 2 doses for Pfizer. Israeli data showed 39% effectiveness for infection after 6 months, 2 doses of Pfizer. Basically, Delta has changed a lot of the things that we knew about cross immunity and about effectiveness of the vaccine, because it has a very high viral load, one, and it could be transmitted by people who have been vaccinated. And of course, in the United States, the fact that CDC in May said you don't need to wear a mask when you are indoors, that has set us back a lot in the United States. And unfortunately, we've seen a rise in infection where people who are vaccinated are playing a role in spreading the virus. And this is what we had before. The Qatar I'm providing here is the previous study that they had. Now they put out a study by time, waning immunity by time. So with time since vaccination, how much waning immunity, and there is a change in what I'm presenting here. So I didn't have a chance to add it in my slides because the study was put up yesterday. But right now we're looking at a vaccine efficacy about 75% for Delta, 6 months after vaccination. Immunity wanes so fast. About 6 months, we know there is a need for a booster to prevent infection, not hospitalization and mortality. And there is very low cross variant immunity from one variant to Delta variant. What we are watching right now is how P1 will interact, the one that's circulating in South America, how it will interact with Delta, but we believe Delta will take over. But we don't know exactly today how much cross-variant immunity P1 does provide against the Delta variant. And we provide this, we update this on a regular basis. This is how we believe right now efficacy of the vaccine against the infection from the old variant Alpha, and how much it is effective or efficacy against the Delta variant. And to give you an example, Johnson & Johnson is 92% in preventing disease, 86% was in preventing infection, Pfizer, and it went down to 90% and 78%. We believe that 78% will come down a little bit now with more studies coming up from Qatar and Israel and elsewhere. The way we do our models, we look at the reported infection, daily infection. This is an example for Alabama, and daily reported hospitalization and daily reported deaths. And we put the three together. Based on these three, we can get, of course, cumulative cases, cumulative deaths, cumulative hospitalization. But we can get infection detection rate. And how we get that? Because we have these seroprevalence surveys that are reported. So we know how many infections are reported. We know the true reality, and we know we can pull out an infection detection rate. We can get infection hospitalization rate. We know how many infections are out there, how many people are hospitalized. We can get, of course, infection fatality rate, because we know how many people have been infected, how many people have died. And the bottom right on my screen showing the circles, the purple circles, these are seroprevalence surveys, two types of seroprevalence surveys that we use in our estimate in order to correct what is being reported and what's not being reported by a state, depending on the testing capacity and how late testing is. And that allows us to put projections. We project those. We have a nice visualization on our web with all the data available, all the data sources. You could check it out, IHME COVID-19 projections. And we believe in the United States, we are coming to a peak right now, and we'll start coming down all the way. The green line is what we believe is most likely to happen. Of course, if people wear a mask to do a much better job, we believe about 50,000 deaths could be saved between now and December 1st. We end our projections here to December 1st. We do 4 months projections. And of course, we provide a worst case scenario where people stop wearing a mask, mobility increase, and vaccination doesn't go up as we are expecting or we're seeing as a rate of increase in the vaccination right now. There could be a worst case scenario. Opening school, for example, could cause a worst case scenario. And I'll talk about this a little bit more. And we do long range projections. We don't release these ones, but I wanted to share with you. And here, worst is the blue, basically saying if we don't wear a mask and mobility increase, best mask is 95% of people wearing a mask when they are outside. public reference is what we released the week before, and reference is what we released this week. So you could see a change from one week to another sometimes in our projections. But basically what we are projecting here for the United States, that mortality will decline all the way till January. We'll have a little bit slowing down. December, it will slow down. January, it may go up a little bit and then it start declining. It will not we will not have a surge in the United States this winter simply because we have seen a surge right now in summer. Basically, this virus is seasonal, like pneumonia. We see it following the pneumonia patterns in every country, in every location. But because we had an infection rate, very high infection rate in the summer and a big surge, many people will be immune to the Delta variant, and a combination of vaccination and immunity from vaccination. We believe about 71% of Americans by December 1st will be immune to the Delta variant. So cases will keep going down all the way. Of course, the worst case scenario is a totally different scenario, but we can control and contain this virus through vaccines, and boosters, of course, will help. Again, all of this will be true if and only if there is no new variant circulating that makes the vaccine less effective and makes the infection from Delta less protective. We add to all our analysis excess mortality from COVID-19. And we need to remember that sometimes there are deaths that are not recorded COVID-19 because they were not tested when they died. But in addition, there's an increased deaths due to mental health, substance abuse, suicide. People defer their medical care. So we've seen it as physicians. You see it many people early on, especially early on in COVID-19, they were afraid, they stayed at home. We didn't see heart attacks, for example. Immunization went down. There is an increase in obesity. We have data right now showing there is an increase in obesity and smoking in many places. And it's very important. A study in JAMA, for example, in South California showing from Kaiser Permanente an increase in obesity, for example. So there are very studies coming out showing that there is an increase in risk factors. There's also increase in poverty, unemployment, and social disruption that will cause a burden, more increase in the burden of disease. At the same time, if we don't account for it and look at deaths in the population as a whole, there is a reduction in mortality due to decrease in respiratory virus. We haven't seen much flu last winter. There is a reduction due to injuries from mobility because not many of us are driving or outside our home. Reduction in deaths due to competing risk factors, of course. And of course, there is a reduction due to reduced air pollution. We have data showing it's not as much right now, but early on in the epidemic, there was a reduction in particulate matter, carbon monoxide in many places. So we need to keep in mind the impact of new variants. Cases right now in the United States, and that's, as I showed you, even with the new variant, Delta variant, have increased, but we believe we are peaking. Some of the states that have done a good job containing the virus, and they have a lower percentage of people who are infected. My state, for example, we have 19% of our population infected, whereas the average in the United States is 42%. So states like Oregon and Washington, they've done a good job in containing the virus. The percentage of infected is very small. Percent of vaccination is much higher than Florida, but the combination of two puts Florida in a better position. Florida will peak first, then Washington will peak a little bit later. Schools opening is going to be a major challenge. CDC guidelines for opening the school right now take, for example, 3 feet apart from for the kids in school. That was good for the previous variant. That's not true for Delta variant. We know it's more contagious, and 3 feet are not good enough. So we believe some of the mitigation measures in schools may not be good enough for the Delta variant. And of course, in many schools, you hear the debate whether kids should wear a mask and mandates for vaccines or not. Vaccine and mask and reduced mobility will reduce the spread. Vaccination hesitancy is a problem in the US. It has remained around 25%, more so in many states. That's the national average. And these people are saying, no, I don't want to get a vaccine. And I don't believe, quite honestly, that the Pfizer authorization, full authorization will help, because people who are finding excuses not to take the vaccine will find another excuse. Booster or new vaccine, meaning developing a new vaccine that will attack the new variants like we do with flu vaccines every year. We tweak it to be more relevant to what's circulating, will help a lot. But at the same time, fatigue and economy will lead to relaxation. Many countries, many locations will open up. And you see the debate in the United States. But we need to plan for this virus to be annual for the coming 2 years, and perhaps having mandates during the season. Of course, this summer we've seen it wasn't seasonal. It hit us hard during a summer where we didn't expect it. We expected the surge to be in winter. So what are the strategies? This is my final slide to manage the pandemic as we move forward and the epidemic in the United States. Well, we need to continue efforts to reach out people who are hesitant and improve vaccination in the US. Through mandates and other means, you can go to a restaurant unless you show me in California, places in California and here in the city where I live, you have to show that you are vaccinated to get into some restaurants. Mask mandates, very important, whether you're vaccinated or not. School and workplace need to have a test program. Schools, very important, especially for kids who are not eligible to get the vaccine. People need to be vaccinated around them, wearing a mask, and regular testing. So schools cannot be a base to spread the variant or the virus from one family to another and from one bubble and circle in the society to another circle in the society. Avoiding mass gathering in states that Delta is going up and there is a large surge. Right now, we have enough data showing that the spread of the virus could happen outdoors. So we've seen cases increase outdoors after an event. We've had here an outbreak in my state, 168 people, and there is a follow-up right now, and people are being followed. 168 cases during an outdoor concert. So, and of course, we need to make sure we support hospitals and they are ready, especially for the coming winter, even with a minor surge of COVID-19, as I showed you. Unfortunately, we would see more cases of flu because many, especially kids under 2, you hear right now, we're seeing RSV in many places, even in summer, because kids have not seen flu and have not seen any of these viruses during last year, because everybody was staying at home wearing a mask and kids were not around other kids. So we would see a rise in infection in winter from flu and other respiratory viruses, and COVID goes up a little bit. That will put a lot of pressure on our hospitals. Thank you very much. This is my email, and if you have any questions, I'll be happy to respond by email. And I'm so sorry not to be with you in person, to see some of my friends and meeting new friends. Thank you.